Okay, ventricular dysrhythmias. So as opposed to atrial dysrhythmias, which all the problems came from the atria, this time all these problems came from the ventricles. First one is PVC. So if you compare this to the PAC, so it has similar pattern. So what are the five things again we need to know?
Like causes, signs and symptoms, interventions, and teaching.
Okay, very good. Okay, so these are the causes. We'll look at what it looks like shortly. Okay, I'm not reading them for you. Okay, you have the textbook. You list down your notes. Okay. There are different patterns of a PVC, meaning they can occur in any one of these different patterns. They can be the same PVC, meaning they look the same. In that case, we call it unifocal. If they look different, say this one, these are all PVCs, this one, this one, this one, and this one are PVCs. How do you recognize a PVC again? Let's go back to PAC. How do we recognize that there's a PAC? What do we see? A pause, right? So here you have a pause again. So here's a pause. And you look at the wave immediately preceding it. That's a premature beat. Okay, so this is your underlying rhythm. This is your normal rhythm. Okay, it's normal sinus actually. But this is the distance between each contraction. This one, is it the same distance?
No.
No, it occurred prematurely. Okay, so therefore, after a premature beat, it's always followed by a short pause and then it goes back. Now, a PVC can also, if it's like this, these are unifocal, meaning the same shape, like that one, same shape. This one and this one are not the same. So that's multifocal, okay? Meaning when we say unifocal, same source, same thing is causing it. When it's multifocal, different parts of the ventricle are causing the premature beats. And if they occur two in a row, we call it a couplet. If it's three in a row, triplet. Four in a row, couplet. When it's five or more, we usually call it a VTAC now.
VTAC?
Yeah, ventricular tachycardia. Okay, that's now I mean, there's no like 10 tuplets, if there's such a word. Oh, quintuplets. That's nothing. There's nothing like that. So if it's more than four, means five or more, that's ventricular tachycardia already. Okay, it can also be every other beat, meaning let's say like this one. If the disregard this part here, if there's a PVC every other beat, meaning normal PVC, that's bigeminy. 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 So it's every other beat. If it's after every third beat, let's say normal PVC, normal PVC, that's a trigeminy, every third beat. If it's every fourth beat, guess what it's called? Quadrigeminy. You understand? Okay. So they can have different patterns.
PVC.
Ventricular tachycardia. Yeah, VTAC. We'll look at a picture of a VTAC later. You'll see it clearer. And because PVCs, again, the causes are here. Look at the causes: coffee, alcohol, right? Nicotine. So the patient, just like PAC, their main complaint is, I felt like my heart skipped a beat. That's it. That's all they're feeling. It's not serious if it occurs on an otherwise healthy person. But again, if this occurs in a patient with a cardiac history, it can be concerning and must be treated. Medical management, again, if it's on an otherwise healthy patient, no
medical intervention. We simply identify and eliminate the cause if we can. Here's what I meant earlier. So if it's 5 or more PVCs in a row, it's called now VTAC, ventricular tachycardia. That's now more serious than just a PVC. There's an isolated PVC. So if a patient is having a heart attack, for instance, they're here for an MI and you see PVCs, is that serious? Yes, patient may go into VTAC, so that must be treated. So we'll look at the treatment shortly. The treatment, well, it's not mentioned here. The treatment is beta blockers. Give the patient beta blockers. If the blood pressure is high enough, meaning over 100 systolic, we can give beta blockers. That's safe to do, just to cut down on the premature beats. VTAC, here's your picture. That's VTAC. Okay, it's uniform. No P waves, right? No P waves, just abnormal QRS complexes. So is there cardiac output here?
No.
No, the heart here, the heart muscles are wasting energy. They're wasting oxygen. They're consuming so much oxygen. But is there any cardiac output? Very little to none. So do we need to stop this rhythm? Do we need to stop this rhythm? Yes, this needs correction right away. And your interventions are the following. There's no nursing intervention here. It's all pharmacologic. Can you talk your patient out of it? And you say, hey, you want to talk about your feelings, your thoughts? Will that work? No. In fact, if this is a pulseless VTAC, what do?
Oh, that's defibrillation.
Defibrillation. Okay. Defibrillation, if it's pulseless. Now, don't go grabbing the defibrillator whenever you see VTAC. Some patients have a stable VTAC, meaning they have a pulse, they have a blood pressure, they're conscious, they're responsive to you. Okay, so do we defibrillate those patients? No, obviously there's a pulse. Okay, so what's the first thing you do when you see VTAC? I just mentioned, if it's a pulseless VTAC, what do? Defibrillate. Some patients who have a stable VTAC have a pulse, they're talking to you, they're conscious, they have a blood pressure. So what do? Whenever you see VTAC, what's the first thing you do? I just give you two scenarios. So what do?
Medication, or defibrillating. There's a pulse.
I repeat for the last time. There are two types of VTAC. Pulseless VTAC, of course, that's defibrillation. VTAC with a pulse. Some patients have a pulse, are conscious, they're awake, they're responsive to you, they have a blood pressure. So what's the first thing you do whenever you see a VTAC on the monitor?
CPR.
Why do you keep coming back to that? You see VTAC on the cardiac monitor. What's the first thing you do?
Check the leads first to see if there is.
Staring and yellow, both are in VTAC, okay? Her monitor shows VTAC, her monitor shows VTAC. She does not have a pulse. She's unresponsive. What do?
CPR.
She has a pulse. She's awake. What do? CPR?
No.
So what's the first thing you do? You see VTAC on the monitor. What's the first thing you do? Go check your patient. Okay, check for a pulse. Check for vital signs. That's your answer. Okay, check the patient. Again, do I check the leads or do I check the patient? Check the patient. Let's say the patient's leads are on. Does it matter? No, because the patient is in VTAC. So you check, are they pulseless or not? Are we clear? All right. And if they are, therefore, because what's the only treatment if it's pulseless?
CPR.
That's it, CPR, defibrillate. What's the treatment for VTAC with a pulse? These are your medications. So the doctors may order procainamide, amiodarone, sotalol, lidocaine. These are the choices. Doctors make the decision, not us. Any questions on VTAC? All right. Yes. Okay, so here's an option. If the patient has a VTAC with a pulse, so besides medication, so let's say the doctor would choose whether it's chemical. Remember, there's two ways to cardivert, chemical or electrical. So it could be chemical, which is using medications to convert the patient back to sinus rhythm, or electrical cardioversion. Again, do we make the decision? Doctors make the decision. But you'd already know what cardioversion is, right? What's the difference again between cardioversion and defibrillation? Okay, synchronized button must be on. And which one is scheduled? Cardioversion is scheduled. Do we schedule defibrillation? No, like, let's defibrillate him later, 2 o'clock. Okay, are you available 2 o'clock? No, it doesn't work for me. 3 o'clock. Okay, we'll defibrillate 3 o'clock. Can we do that? No. So what Miss Kamika mentioned last week about somebody being cardioverted in the ER, so that is only applicable for new onset stuff. Okay, so we have a chance. So let's say, remember we talked about AFib, aflutter last week. So if it's a new onset AFib, aflutter, and we're sure it's new onset, then we can cardiovert right then and there. All right. What about if it's persistent or has been ongoing for more than 24 hours? Can we do cardioversion? No, now we need to anticoagulate first. Why? Because it's been a while. Correct. There's clotting. So we might dislodge a clot if we cardiovert. Okay, so cardioversion won't be applicable at that point. We'll skip torsade de pointe. This is a form of VTAC. However, this one has a, let me show you what it looks like. It looks like a twisted pretzel. So here are pictures of torsade de pointe. It's a form of VTAC, that is ventricular tachycardia, but look at it. It's like a, well, it's literally French for twisting of the points. Okay, so here you look at it. It's like a pretzel. Okay, so it's VTAC but different shapes. So it's like twisting. Okay, it's like you twisted something. So that's torsade de pointe. That is dangerous because this will go, if untreated, this will go into VFib. But in torsade de pointe, of course, this is a polymorphic type of VTAC. So again, there's two types here, either pulseless or without a or with a pulse. But most people on this rhythm are already unconscious and should be treated right away. It's an emergency, basically. And here's the worst, VFib. Most patients on cardiac arrest are in VFib. So if you find them pulseless, so it's either VTAC with a pulse without a pulse, or they're in VFib already. What's the treatment for VFib?
Fibrillation.
What do you mean depends on which one? Is there different types of VFib? Only VTAC has a variation. This is VFib. So is there a variation here? No. All VFib patients are, do you find them awake? So I can be awake when I have VFib?
I thought I'm mixing it up with A.
That's amazing. So I have a rhythm like this. I'm still awake, walking around, sipping coffee. Hold on, let me finish this cup, okay? And then you can defibrillate me later. Okay, no. VFib is disorganized rhythm. There's no way a rhythm like this will produce cardiac output. Is it? No. Zero cardiac output, zero blood pressure. Causes, usually heart attacks. So here are the causes. Okay, MI, or let's say you've unsuccessfully treated torsade de pointe or VTAC. VTAC with a pulse was not treated adequately. The patient will go into VFib. So therefore, signs and symptoms will be what? The patient is dead. Okay, so patient looks like they're dead and nothing, absolutely nothing, not breathing, no pulse, not moving, unconscious. What's the first treatment again? CPR. Unless you're carrying around an AED wherever you go, then it'll be defibrillation. But who's carrying an AED with them right now? You have one in your bag?
The gyms, some stores will have one. In the mall, I've seen one.
Okay, but until,
carrying one.
because what will, okay, very good.
Yeah.
What will happen though when you have an AED in your bag? Is it always turned on? No, it has to be turned on. It has to be, so therefore, what's the first treatment for VFib? CPR. It's always CPR, even if you have an AED. Just you have to turn on the AED. Okay, so chest compressions. So that will save a life. Effective chest compressions will sustain the patient until you can convert the rhythm. We'll skip idioventricular rhythm. That's not really very common. We'll stay with the most common, which is VFib. Last one is asystole. So this is the last ventricular arrhythmia. Asystole, I mean, it's flat. Okay, flat line. No rhythm, nothing. So what's the only treatment? What were the two rhythms that is defibrillated?
VTAC and VFib.
Pulseless VTAC and VFib. There's only two. So therefore, where will this come? There's no three. There's only two rhythms we defibrillate. Pulseless VTAC and VFib. So what's the treatment for asystole? CPR only. There's nothing to defibrillate here. Correct. Because the defibrillation is to take them out of fibrillation. This patient is not fibrillating at all. There is no electrical activity. Zero. No power in the patient's body. No electricity is generated. So therefore, what can you do?
CPR.
Perform chest compression so that you will generate electrical activity. Does that make sense? Meaning there's no power, zero, no electrical activity in the heart whatsoever. So what do? Perform chest compression so that we will create electrical activity. Okay, so instead of the heart pumping, we will pump the heart instead. Okay, so the patient's heart cannot pump on itself on its own, so therefore we will do it externally. Okay, so we perform effective chest compressions. Blood will get moving. So as soon as blood gets moving, will blood go in and out of the cells now? Correct. So coronary vessels will fill with blood, fill with oxygen. It will push electrolytes in and out of the cardiac cells. Will that generate power? That will generate electricity. And then the first rhythm that usually starts once you generate after a heart stop is ventricular fibrillation or VTAC. So once that happens, then we can defibrillate first. Okay, right. So chest compressions, and then you see, we have VFib or we have VTAC. Then you can defibrillate. All right, you understand? Okay. So while during chest compressions, of course, you guys don't have ACLS yet, but during chest compressions with ventricular asystole, of course, we want to jumpstart a rhythm, right? So drugs like epinephrine will be given, atropine will be given to force the heart to start working, okay? To force it to begin pumping again. All right. So again, but can these drugs circulate without chest compressions? No, chest compressions is necessary. Okay. So non-stop chest compressions, we give epinephrine, we give atropine. Those drugs will eventually reach the heart, and then it will jumpstart a heart rate. Okay. That's it. Any questions on those? Okay, so we're finished with ventricular dysrhythmias. Now let's do conduction anomalies. So there are 4 conduction problems. When we say conductions, we're talking about the electrical conduction from the SA node to the AB node. Okay, there are 4 types of heart blocks. Let's talk about the first one. So these are some of the causes of heart blocks. So you got medications. Remember, we talk about medications. What do all antidysrhythmics do? Cause another dysrhythmia, correct? Right. So this is one of the consequences. So if you're giving the patient any AV blockers like beta blockers, calcium channel blockers, they have the potential to cause heart blocks. Okay. Other medications are digoxin. Okay. So those drugs are very notorious for causing heart blocks. First type is first degree. So this is the most minor among the 4. The only thing wrong in first degree heart block is that the PR interval is longer than 5 small blocks. I repeat, the PR interval here is longer than 5 small blocks. It should only be how long? 3 to 5 small blocks. This one is more than 5 small blocks long. So it's greater than 0.2 seconds in duration. All other properties are normal. Okay? If not for the PR interval being too long, this would look like sinus rhythm actually. Because that's the only thing wrong. Will these patients usually have symptoms? No. Patients with first degree heart blocks are usually asymptomatic. Okay, you and I could be having first degree heart blocks right now. We would be totally fine. Right? So there's usually no intervention needed here except to investigate what's the probable cause. Okay, could it be the medications that are causing first degree heart block? Okay, that's all we do. And if we can afford to stop them, then they will be stopped. But usually the patients are on beta blockers or calcium channel blockers for a reason, correct? So all we do here is observe the patient. The next problem is second degree type 1. This one, compared to type 2, is milder. So here is what second degree type 1 looks like. In type 1, the PR interval is long, gets longer, and then even longer, and then you lose 1 ventricular contraction. You lose 1 QRS. That's always the pattern. I repeat. In second degree type 1, the PR interval is long, gets longer, and gets even longer, and then you lose 1 QRS complex, meaning it's blocked. Any questions on second degree type 1? Okay, let's go to second degree type 2. Second degree type 2, the PR interval remains the same. Here's type 2, second degree type 2. The PR interval remains the same length. It does not get longer, and longer, unlike type 1. However, you lose more than 1 QRS complexes now. See here, you have complete QRST, PQRST, and then you have a P, but no QRS. No QRST. Then here you have PQRST, and then you don't have one again. So every other beat, no QRST. Does that make sense? So therefore, is it serious? Because what will happen to your total minute heart rate here, ventricular heart rate? What happens to the patient's heart rate every minute if it's losing a QRST every other beat? What happens to your heart rate? That was the question. What happens to the ventricular rate? It will be significant or mild? This is severe bradycardia as a result. So therefore, is this serious?
Yeah.
Yes, this is more serious compared to type 1. Okay, type 1, you're not losing that many that many QRSTs. Okay, you only see a few missing. But in second degree type 2, how many are you missing? A lot. Every other beat is missing a QRST. Okay, so the heart rate here is in the 30s or in the low 40s. Is that compatible with life? No. Third degree, which is the most serious. Look at this pattern here. This is third degree. This is third degree heart block. Not inverted. Okay, so look at it here. Can you identify the P waves?
No.
Why not?
Okay, where the arrows?
Yeah, that's the P wave. P wave. So if you look at it, the P wave pattern is normal. See, it's regular. We have another one here, there would be a P wave there. It's normal. Look at the QRS complexes. Look at the R's. That's an R. 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 So what can you say? Are the P's and the R's regular? Yes or no?
For this type of heart rate, yes.
Okay, let me repeat. So these are your P waves. Okay, so those are your P's. P's are occurring regularly. Okay. They're regular. These are occurring regularly. The R's are also occurring regularly. Yeah,
Yes.
totally regular. Is there a P for every R?
Yes. Yes.
This P has an R. This P, this P. No,
No?
not every not every P has an R wave. It's supposed to be PQRST, right? PQRST, PQRST. Is every P paired with the R, with the QRS? No. That means, so if you think about it, is the SA node firing normally?
No.
There's a P wave. Is it firing normally?
Yeah.
Yeah, there's a P wave. So yeah, so it is. Is there a QRS for every P?
No R for this picture.
Yes, there's a QR.
There's a
There's a R.
QRS for each one?
No, I said no.
Oh, the,
No.
yeah, the R's are missing.
Yeah.
No
This
R to the P.
is not, it's not paired correctly, okay? So therefore, can you say that every SA impulse is reaching the AV node?
No.
No. So this is what we call a complete heart block. A third degree heart block is a complete heart block, meaning is every P wave impulse reaching the AV node? Not at all. Remember, the AV node, is it a pacemaker? Secondary, primary, is it a pacemaker? It is a pacemaker. So if it's not receiving any impulse from the SA node, will it generate its own? You just said it's a secondary pacemaker. So this is what's happening here. The SA node is firing. The AV node, is it receiving those impulses? AV node doesn't know what's going on. So what will the AV node do? Because it's a secondary pacemaker. What will it do? It will generate its own. But how many impulses can the SA node fire minute by minute? 60 to 100. How many can the AV node fire minute by minute? 40 to 60. So in this type of rhythm, will there be the same atrial and the same ventricular heart rate? No. The atrial rate will be normal. It'll be 60 to 100. A ventricular rate will be 40 and 60. Is this compatible with life? No. Let's go to the treatment. So what's the treatment for first degree?
No.
What do we do for first degree?
No treatment.
No medical treatment. Okay, what do we do then? Nothing? Just relax. Which is what? Would we maybe look for a cause and try to eliminate? Okay, that's all we do for first degree. Second degree type 1? Depends if the patient is symptomatic or not. No symptoms, do we really need to treat it? No. So same thing as first degree, we look for a possible cause and eliminate it. What about second degree type 2? These need to be treated. Well, you think these patients will have symptoms? Look at yes, that's the rhythm. Okay, this is second degree type 2. Yes, the heart rate is now considerably low. It needs to be treated. The treatment is atropine. It's listed in table 22-1. So the treatment is atropine. So you give atropine IV. It can be repeated every 3 to 5 minutes, okay, until the heart rate is 60 or better. Now, if this persists, can we atropine the patient forever? No. If the rhythm remains second degree type 2, we have to put the patient on a pacemaker. We have to apply a pacemaker. Now, there's no emergency pacemaker insertion. Okay, meaning if the patient needs a pacemaker permanently, we're not calling a team in at midnight or 3 o'clock in the morning. Okay, the patient will be on a external pacemaker. You remember the defibrillator we showed you last week? That defibrillator is also a pacemaker. Okay, that's all we do. Put the pads on the patient, turn the pacemaker function on, select the rate you want, and the patient will have a temporary pacemaker. Understand? Okay, that's all we do. And then until the morning, then we'll take the patient to the OR and then we'll insert a pacemaker. All right. So there's no need to call anybody in, okay? Because we have a emergency temporary pacemaker. Now, in the case of, let's say I have an infection. Right now I'm septic, but my rhythm is second degree type 2, or maybe I'm in third degree heart block. I need a pacemaker. Do I need it temporarily or permanently? I need a permanent pacemaker. In that case, I can put a temporary but internal pacemaker called a transvenous pacemaker. The one I described earlier using the defibrillator is transcutaneous. Why transcutaneous?
Closer to the surface.
Okay, it's only pacing through the skin. This one is pacing internally. However, right, here in transvenous, the wires are inside the patient's heart. It's in the ventricle, the wire, but the pacemaker machine itself is outside. Does that make sense? Okay, so this is transvenous, this is transcutaneous. Because is it comfortable for you to feel electrical impulses through your skin for more than a few hours? Yeah, very uncomfortable. Okay, you're walking around attached to a big machine and it electrocutes you 60 to 100 times a minute. Is that comfortable? No. So if you need long-term pacemaker, but you have an active infection, I cannot put a permanent pacemaker inside you yet because what will happen to that pacemaker that I implanted you if you have if you have a current infection in the blood?
It'll get attacked.
The organisms will attach to the pacemaker that I'm implanting. They'll live there. Okay, they'll say, thank you. Now we have a house to live in. Does that make sense? So I have to treat the patient's infection first, make sure you're infection free, and then I can put a permanent implant in you. Does that make sense? Okay, so we call this method a bridge. Okay, it's a bridge until you get a permanent pacemaker inside. Any questions? So for temporary pacemaker, you can either have transcutaneous, good only for how long? A few hours. Transcutaneous, a few weeks. Okay, and then of course we will have a permanent pacemaker, which can either be regular pacemakers have leads. Nowadays, we have leadless pacemakers. You've seen a pacemaker? It's a round device, right? Round or circular or yeah, so or you know, like a square with round edges. Okay. We're still in the same chapter. We have not progressed yet. All right. We do have leadless pacemakers now. Leadless are this size. That's the actual size of a pacemaker. Right? It's implanted in your ventricle. It's leadless. So will you see a big machine? You won't even see it because it's inside the patient's heart. Okay, it's very small and it has a battery inside and all that, lasts for 10 years. Okay, so these are modern leadless pacemakers, right? So in case you see, you assess a patient and then they're on the monitor, oh, how come I'm seeing pacemaker spikes, but you don't feel any implant? They probably have a leadless type. Okay, so modern pacemakers are leadless. Again, who chooses it? Of course, it's the cardiac electrophysiology specialist. Okay, they will choose whether you're a candidate for leadless or if you're a candidate for a regular pacemaker. Any questions about the three? Okay, so next topic will be pacemaker therapy. We already talked about cardioversion and defibrillation and EPS with ablation. Here's pacemaker therapy, also called cardiac resynchronization therapy, CRT, is pacemaker therapy. It may be built, they may have an ICD. ICD is a separate page. Okay, but know that we can have dual pacemaker and ICD implants. Okay, they can be 2 in 1. Right. So I described to you the different pacemakers. We have external or temporary pacemakers. We have permanent pacemakers, which are implanted. Okay, so for external pacemakers, we have transcutaneous or transvenous. Then permanent pacemakers, of course, are implanted internally. So here's your traditional pacemaker. Okay. So it's implanted on your chest wall, either left or right side. And the electrodes, of course, are inside the ventricles. Right. So questions on exam will be, what do you teach the patient? Who has a pacemaker?
Medication adherence.
Now, there's no table or chart. They're all in the paragraph. Let's discuss ICD because the teaching are the same for both pacemaker and ICD. So they discuss them all in the same paragraph. What you're seeing on the picture here is a vest. This is a, remember we had an external transvenous pacemaker wherein the pacemaker is outside but the wires are inside. Okay, we also have a, just as we have an external pacemaker, we also have an external ICD. So this is an external ICD. You wear this straight over your skin. You don't wear a shirt and then put this over the shirt. No, you put this on your skin, on directly on your body, and then you put a shirt over it, right? This is a temporary external ICD. This brand is from, I believe this is Zoll. Yeah, Zoll. Okay, so this is a Zoll brand. So what it is it's an external ICD. It's an external defibrillator. So you wear it. It has a power pack. See, a large battery pack, and it will detect VTAC, or what are those two rhythms again that are defibrillated? VTAC or VFib. So if you throw a VTAC or VFib, the machine will automatically give you defibrillation. Okay, so you'll feel electric shocks. Why this compared to an implanted? You remember this concept here, the bridge? Okay, so the patients who get this are probably those who have a current active infection, wherein we cannot implant a ICD yet, but they're high risk for VFib or VTAC. They need an ICD, so we'll give them an external ICD. Does that make sense? Until we resolve the infection, and then we'll give them the permanent implant. Any questions? Right.
The admissions, they have an issue that they need to wait. to get it.
Correct. So patients who we have indications here. Okay. So who gets an ICD? So here's the answer. Thank you for reading the first few sentences.
Implantable cardioverter defibrillator, ICD, is an electronic device that detects and terminates life-threatening episodes of tachycardia or fibrillation, especially those that are ventricular. Patients at high risk of VT or ventricular fibrillation and who would benefit from an ICD are those who have survived sudden cardiac death, which is usually caused by VFib, or have experienced spontaneous symptomatic VT, syncope secondary to VT, not due to reversible causes. Patients with coronary artery disease who are 40 days post-acute myocardial infarction with moderate to severe LV dysfunction.
Left ventricular.
What is it?
Left ventricle.
Left ventricular dysfunction, ejection fraction less than 35%, are at risk for sudden cardiac death, and therefore ICD is indicated. Primary prevention.
All right, and then last, ICD is also recommended in those with class 2 or class 4 heart failure. So those are the indications, right?
Class 4, class 3, right?
Mm-hmm. Yeah. But I mean, they have not just any class 2 or class 3, but they have dilated cardiomyopathy. So they have dilated cardiomyopathy for at least 6 months and have been diagnosed with class 2 or class 4 heart failure.
They have to wear this forever?
No, like I said, the
Oh, yeah.
best is only if you have an infection of some sort. Okay, we cannot implant the ICD yet. But of course, our goal is to implant the ICD in your chest. Does that make sense?
Yeah, so this might be a stupid question, but are they plugging it in every night or? Is there-
Which one?
The vest, the IC.
Of course, yeah, the vest would, of course, if it's the Zoll, yeah, if it's this one, because it's no, it's an external battery, yeah, you need to charge it, yeah.
That's wild.
Is it heavy?
Very, yeah, it is a large battery.
It's not in
The vest?
yeah.
Well, the vest itself, I mean, it's Velcro, you know, I mean, it's a canvas, so it's light, but the battery is heavy. Because you need a lot of power to defibrillate somebody, yeah? Yeah, I mean, you've seen an AED. Is an AED only less than a pound? No, an AED is heavy because of the battery. If you don't want the battery, yes, you'll have to be plugged in somewhere. Plugged into your Tesla or any electric car. So we can do that. But you need a lot of power. Okay. Okay, let's go now to your patient education. What must they observe when they have either an ICD or a pacemaker? Like I said, it's not in a paragraph. I mean, it's not in a table or chart, which you were hoping there would be, right? Okay, there's one chart at the end, but here are the first few. So here are your instructions. So if it's fresh, the incision site, here's the care. Okay, what to report. Please read on your own. And then the rest of the teaching will be okay, right here, beginning here under. So first we have preventing infection, and then we have effective coping. So here are some of your interventions. Okay. And here's your teaching in a summary. But again, most of them are in the paragraphs. This one is not very complete. Chart 22-8. This is both for ICD and pacemaker. Does that make sense? Because the title of the chart, is this really ICD or pacemaker? No, it just says implantable cardioverter defibrillator. Okay, so it could be, yeah. Actually, that's not the chart. It's this one. This one is the one I'm referring to. Chart 22-9, sorry. So chart 22-9 applies to both pacemakers, implanted pacemakers, and implanted ICDs. So here from clothing, of course, taking temperature is, to prevent infection or at least catch infection early. Here's the clothing. Yeah.
They remove, because it says it's a terminates tachycardia and fibrillation. It's not shocking me.
It does. That's what an ICD is. It's a cardioverter defibrillator. So it delivers shocks because the patient had VFib or VTAC, pulseless VTAC, then it will shock the patient.
The only difference between a pacemaker and the ICD is.
Well, ICD is a defibrillator. Pacemaker this is pacemaker. No, it will fire instead of the SA node. This is now your pacemaker.
It's not.
Oh,
It makes your heart beat. Okay, pacemaker makes your heart beat. This more.
Yeah, it's a pacemaker. Just like your SA node. Okay, you have an SA node, so obviously you have a problem with your SA node, heart blocks. So who gets a pacemaker again? Second degree. No, that's ICD. Hey, who gets a pacemaker?
Second degree, second, and third degree.
Second degree type 2.
Type 2.
Okay, second degree type 2 and third degree heart block. Those two get a what? A pacemaker. Are we clear?
Yes.
All right. Okay, so here's your other teachings. So these things operate under any electronic device emits magnetic fields, correct? Your car, a battery, your speakers, okay? All these electronic devices, that's why they have the capacity of doing what they're doing because there's a magnet there, correct? So engines have a magnet because otherwise, how will it turn, right? So you require a magnet. So therefore, can it be not damaged, but can it malfunction if you're exposed it to nearby magnets? Okay, so what other machines therefore have big magnets? So, right, yeah, engines, large engines, okay, whether it's a car engine or a plane engine, those things have huge magnets. MRIs are huge, okay? So therefore, what else? Welding equipment, okay? Those things have very high magnetic waves. Yes.
The airport going through the security. at the
Yes,
airport.
anything again that has magnets, okay? Anything electronic, those things operate with magnetic fields because they have machines. So any machine that turns any engine requires a magnet, okay? So the only thing that won't require a magnet will be what? Once we perfect fusion, right? Nuclear fusion, then you don't have a magnet, right? Or nuclear power, something nuclear powered, yeah, you don't have an engine there, okay? Although not all, because that's just really a source of power. So never mind. All right, so here, you mentioned the security devices, okay? Anti-theft or weapon detection devices, okay, at security terminals, whether in the mall or in the airport. Phones, okay, can also interfere with the device. Our phones have magnets too. Okay, microwave ovens. What does this say? Thank you for reading.
One says microwave oven should not cause any concern.
Okay, are we clear? All right. So the signs you see on older hospitals, we still see these signs, especially Bellevue, a Metropolitan. These are old hospitals. Okay, they're over 100 years old. These signs are also over 100 years old. Nobody just took the time to chisel them out of the wall. Okay, those are old signs. They doesn't apply anymore unless you have 100-year-old microwave oven, right? So yes, you should get rid of those microwave ovens, okay? But the modern microwave ovens, digital microwave ovens, are safe to use around pacemakers or ICDs. Are we clear? Okay, so what does this say here? Call 911 or okay, so that means what if the pacemaker fires? What do they do? Call 911. Because why did it fire? Because it detected what? VFib or VTAC. You sustain VFib or VTAC. You think this small device can take care of you? Like it fires, oh, I'm glad I have ICD. Okay, let's continue smoking and drinking. Of course not. There's something wrong with your heart. It just went into VFib and VTAC. So do you need to call somebody? Call 911. Or if you feel fine, then drive yourself or have someone drive you to the ER. Okay. But either way, do we notify your provider? Yes. And if you call your provider, your provider will tell you, okay, good. Thank you for calling me. Go to the ER. All right. Because we need to check you out. Then maybe there's some, medication adjustments that need to be made, or we need to add medications temporarily. Okay. Of course, this can occur in usually what will trigger VFib or VTAC? What did it say earlier? A heart attack, or does it involve some strenuous activity? Yes, right. So any activity that causes increased heart rate. Does that include sexual intercourse or sexual activity? Yes. So yes. So therefore, if this occurs during sexual activity, can the partner also be shocked? Yes, although it's not, it's not like a 110 volt. Okay, it's not like that. So there'll be some shocks, but not really the electrocution type. Okay, so yeah, the partner will feel the shocks. Just reassure them. Yeah, it may fire during sexual activity, but it's again reassure them. This is not 110 volts, right? This is a small battery, so it can only generate small electrical shocks. Okay. So the partner may say, oh, I'll never be intimate with you again because you might electrocute me. Okay, so reassure them it's not that much. Okay, it's not that bad. What do they do again whenever it does fire? Okay, or at least drive to the ER. Okay, if it's not, if it fired once, right? go to the ER. But if it's like, sometimes this malfunctions also, like won't stop firing. Eh?
That's a battery.
Yeah, so either way, you call 911. That's it for electrical conduction problems. Any questions? Okay, take a 15-minute break. Come back 12:45.